Okay, I have finished wiping all of the virus off of my hands, and now we're going to, I'm going to show you some manual traction for the cervical spine. Just a little clinical note, if you're ever working with someone, as you all know, I work with patients who have been in auto accidents for the most part, so a lot of them have cervical and lumbar issues. So just a little clinical thing that I've learned, always start with the neck and head. That way you can go to the feet. But if you start with the lumbar spine, you're getting foot and shoe and stuff all over your hands, and then you're gonna move up to the neck. It's probably the best thing. It's gross.
Johnny likes it in that way.
Yeah, Johnny, we know how much Johnny loves feet, so. Okay, so I'm gonna show you the quote unquote traditional method. This is the method that James Syriac's kind of brought about when he first started doing studies on manual traction. He was a big dude, bigger than me, but what he would do is grab underneath the head like this, grab underneath the jaw. You can see how I'm getting my, my body mechanics here. And then he would lean all the way back. As you can imagine, this is contraindicated in people that have TMJ issues or any dental issues that may cause them pain. I typically, because of the amount of pressure that we need to cause changes in the cervical spine, putting that much weight through it is typically not necessary. So grabbing around the chin is a little excessive. How I will usually do it, because like I said, we only need about 7 pounds on the low side to start making a difference, and 15 pounds to actually affect the disc. And that can easily be achieved with our hands. So with the patient in a neutral position, or fairly neutral because you have to get the hands there, I will grab a hold of the occiput using my second finger on both hands. I'll overlap them just like this. And then using my thumb, I'll give it a slight medial pressure. That way we can effectively grab the head and pull it. So when you're pulling traction, same sort of thing. Right here, all I'm basically doing, and you can see my elbows are rested on my knees, so that takes out a lot of the work from the elbow and the shoulder. And so I'm mostly just using a slight bit of weight pulling back and a little bit of radial deviation to get the pressure that I'm looking for. So pull back. And then if we want to vary the area of the spine, again, we'll talk about this a little bit in lecture, we can bring them up into flexion. Or if we have him off the edge of the table, which is how I typically prefer to do it in the clinic, that way I can get a true neutral position, and it's very easy for me to rest my hands right here against the edge of the table. And basically all I'm doing is a little bit of flexion, a little bit of radial deviation to get that traction. The traction can also be used to, you can pinpoint certain parts of the cervical spine or the intervertebral foramen from one side to the other by side bending or side flexing, lateral flexing the neck. When you're doing that in conjunction with traction, this is very, very important. You want to pull first. So right now I'm pulling traction. Then let's say I'm going to target that left side. So I'm actually going to side bend him to the right to open up that intervertebral, those intervertebral foramen. And that's where I'm going to hold my traction. But notice the very important part, I started pulling traction before I put him into the position. I'm going to hold traction here for however is indicated or until my arms fatigue. Then I'm going to bring him back into neutral before I release the traction. Once he's back into neutral, I can release the traction. You can do the same thing if, let's say, if we are trying to elongate some tissues and somebody is having difficulty with rotation, you do the same thing, pull traction, rotate the head for your indicated amount of time, then rotate back and release. The advantage of this, so advantages and disadvantages with mechanical traction, obviously you can hold that for quite a bit, or the patient can hold that for quite a bit longer. So you allow for creep of the tissue. However, it's not as finely tuned. If a patient is experiencing pain or peripheralization of symptoms, if the pain starts going down the arm, or if we're doing lumbar traction starts going down the leg, you can't fine tune that as well as you can with manual traction. So if they start having those symptoms, I can just back off just a little bit. Now the downfall of manual traction is, number one, it takes up time from the clinician. And number two, especially with new clinicians, your hands, your arms will get very, very tired. So you don't quite get as much creep as you would with a mechanical application. So that's that.